Hello all, welcome to my show Chronicles of a Learner RN, and thank you for listening. My name is Ritika, I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today we'll be talking about all things heart attacks, heart conductivity, and ECG for dummies. As a disclaimer, I will not be providing any personalised information, and all names, numbers and results will be altered to protect the privacy of the patient this story is derived from. So we'll get on to context. To be honest, today guys, I don't really have a story to work from, so we'll just make one up as we need it. The cardiac system is a very complex and interesting system in our body. We discussed recently that the heart can act as a compensatory system to ensure all aspects of us get the blood and oxygen we need even when our body is failing us. It works in both an electrical and mechanical sense. We spoke previously about the mechanical aspect. Today we'll talk about all things electrical in the heart. So let's start off with ECG for dummies. What is an ECG? ECG stands for electrocardiogram and is a representation of the electrical circuit of the heart. The electrical circuit can tell us a lot about what's going on and what might be going wrong when something does go wrong. The essence of ECGs is an understanding what each wave means, as well as how far apart the waves are and whether the waves are in line with each other. So let's break it down to the absolute basics. There are three waves as such to the normal ECG waveform that correspond directly to how the heart functions. To understand that, we'll have to discuss the chambers of the heart. God, I wish I had a diagram to show you all, but there are four chambers of the heart. Two top ones called the atria, or atrium if singular, and are about half the size of the bottom two chambers called the ventricles. Now, a normal heartbeat consists of a lub and a dub. Lub is the atria squeezing or contracting, and the dub is the ventricles contracting. But if we want to get a bit technical, the actual lub-dub sounds are the closing of the mitral and tricuspid valves, as well as the pulmonic and aortic valves respectively. On a normal ECG, there are three distinct, in quotes, waves that we see and should expect to see. These are the P wave, QRS complex, and T wave. P wave represents atrial depolarization, aka contraction. The QRS complex represents ventricular depolarization, aka contraction. And the T wave represents ventricular repolarization, aka relaxation. So Ritika, you ask, when do the atria relax? Because you didn't really mention it. Well, lovely listener, it's a bit of a trick question, because the atria repolarize or relax at the same time the ventricles contract. Because ventricular depolarization uses more energy, it creates a bigger surge on the graph, and the signature of the atrial repolarization is hidden within ventricular depolarization, not that we see it. I implore you, if you're listening, to Google normal sinus rhythm on Google Images or whatever, and look at the photos that they provide for an accurate representation of what these waves should look like. Now that we know what the waves are, what they signify, we should discuss distance between each section. Why is the distance significant? In basic terms, because we'll discuss specifics in a little bit, the distance between each section is required to understand just how long it takes an impulse to make it from section to section. And we'll talk about sort of impulses in depth soon. So the different intervals we commonly think about are the PR interval and the QT interval. Mind you, all the letters are just P, Q, R, S, T, nothing else. So P to R and Q to T. There are different reasons for both, which we'll go through in a little bit. But before we continue, let's quickly discuss the systematic interpretation of an ECG. Just in case you ever need to systematically interpret an ECG. So first we must assess rate. Usually the ECG will tell us, but it's good to be able to map it out. Assess rate, we take the number of big squares between two of the R waves, which is the pointy bit of the QRS, and divide by 300. So 3 big squares divided by 300, for an example, would be 100 beats per minute. And 4 big squares would be about 75 beats per minute. Next, we must assess regularity. For this, we map out the R waves and see if they match up or are off. So we map them out on an extra piece of paper, and we go and we physically check whether the markings line up with each heartbeat. Usually there would be a degree of irregularity, like they won't line up perfectly all the time, and that's fine. It's just when you've got an irregular heartbeat, you'll probably have like maybe 2 in the space that there was 1 and 1 that doesn't match up with the line that should be there. It's very obvious when it's irregular and regular. Next, we look for a P wave. Oh, Siri. Let's assume it's there for now, and we'll discuss soon what it means if we don't see one. P wave indicates atrial depolarization. It should be upright and rounded in a few squares before the QRS. Next, we assess PR interval. It should be 5 mini squares or 0.2 seconds or less. We'll discuss soon what it means if it's longer. And next, we look at the QRS complex. It should be less than 3 mini squares or 0.12 seconds. And for that to work, each mini square is 0.04 seconds. So each big square is 5 mini squares or 0.2 seconds. If it is wider, that is not good and indicates that electricity is taking too long to get through the ventricles. They're already in the ventricles. It's taking too long to get through the ventricles. Next, we assess ST segments all over, which we'll discuss in length next. And then after that, we look at the T wave. It should be upright, rounded. If it is too tall or has an extra wave before it, this is a sign of high or low potassium. And lastly, we look at a QT interval. It should be about 0.32 to 0.40 seconds, so about 8 to 10 mini squares. And we also look at whether the waveform is isoelectric, elevated, or depressed. Now, I understand that a lot of this doesn't make much sense, so let's delve a bit deeper. And to do that, we'll be discussing heart attacks. 2 types, in fact. STEMI and NSTEMI. What are they? Why are they different? And what do they do? What do they have to do with the word isoelectric? STEMI stands for ST elevation myocardial infarction. We were just talking about intervals, so using that quick knowledge, possibly open your Google tab, we can see that the S wave and the T wave are adjoining. In normal sinus rhythm, this line usually is in line with the entirety of the waveform to make an overall straight line. But in a STEMI, you'll find this small section of the waveform to sit unusually above where it should be sitting in normal sinus rhythm. If you Google STEMI, you'll find photos of just how abnormal it looks in comparison to normal sinus rhythm. Or I'm going to start calling it NSR. But what does it mean in terms of heart function? Now, I've just said that this is a heart attack, so why aren't we dead? Well, there is a difference between heart attack and cardiac arrest. But heart attacks can lead to cardiac arrest if not properly fixed. In a STEMI, the arteries that provide the heart with the blood to function are occluded or blocked off. This is usually due to plaque. However, only when heart tissue begins to die do we see changes on the ECG in terms of ST elevation. Tissue death is irreversible. The only thing we can do if this begins to occur is to open the blocked artery and prevent further tissue death. So basically, if you're seeing ST elevation, tissue has already died as a result of no blood flow. This is called an infarction. So then if a STEMI is tissue death, what is an NSTEMI? Like I said, this is where the terms ischemia and infarct begin to dictate what kind of heart attack is happening. An NSTEMI is primarily ischemia. And it's like you guessed, it's non-ST elevation myocardial infarction. The heart is not getting enough blood from a partially occluded artery to work properly, but is getting just enough to not cause tissue death. The same way we get pain from a stitch, which is gut ischemia, the heart is the same. We get chest pain from lack of blood flow to the heart. So the differences between the two after that explanation are pretty self-explanatory. One can lead to death if not rectified, and the other one can progress into a STEMI if not rectified. Now, how do we know where and what artery is affected? This is where lead groupings come into play. It is called a 12-lead ECG, but I'd only realized a few months ago that there are only 10 leads. I know, incredibly embarrassing of me. There are 4 limb leads, right arm, left leg, right leg, and 6 chest leads, V's, 1, 2, 3, 4, 5, 6. They go in various spots in the chest, in the intercostal spaces, which are spaces between the ribs, and follow the rib cage down the left side of the chest. These 10 leads together give us a great deal of information on multiple aspects of the heart. Limb leads give us leads 1, 2, and 3, dictated by Roman numerals. These give an overview of the voltage between right arm, left leg. 1 is between right arm and left arm. Left arm. Oh God, can't speak today. 2 is between right arm and left leg. Left is between left arm and left leg. There are other views directly on top of these limb leads, which are AVR, AVL, and AVF. In writing this, they are quite easy to figure out. AVR is positioned on the right arm, AVL positioned on the left arm, and AVF is an AV foot is on the left leg. Thinking about where our heart is in our chest and which way it faces, which is the left side of the chest, the waveform on AVR, which is looking opposite from the opposite viewpoint, will be, again, opposite to the rest of the waveforms. This is why on an ECG you'll see and should expect AVR to be inverted as compared to the rest of the ECG. If AVR is upright, it's a telltale sign that your leads are on wrong. So those are all the limb lead combos. Let's look at chest leads. V1, 2, 3, 4, 5, 6. V's 1 and 2 are called septal leads. They sit on top of the sternum. 3 and 4 are called anterior leads because they sit on the anterior, which is the front of the heart. And V's 5 and 6 are called lateral leads because they sit on the side. Leads 1 and AVL are called high lateral, which are then roped into the lateral category. Leads 2, 3, and AVF are called inferior leads and look at sort of the right side of the heart, more under the heart, but not really. We'll get into it. Lead 2 is the lead you'll see highlighted at the bottom and is the one that gives us a really good overview. This is because it follows the natural direction of current from the right arm to the left leg. So we now know lead groupings, which arteries are affected. What? Which arteries are affected? There are 3 main arteries. Right anterior descending. I think that's right. Let me Google it real quick. Yeah, I was right. Right anterior descending artery and the left anterior descending artery. These, oh no, I forgot the third one, and the left circumflex. God, I'm just all over the place today. Oh, okay. Yes. And the left circumflex, which this branches off the LAD. Inferior leads look at the right anterior descending artery. Lateral leads look at the left circumflex. And the anteroseptal leads look at the left anterior. It's a lot to process, obviously, because even I have just forgotten today what my little abbreviations are. But the main takeaway I want you to get out of this is that there are 3 main arteries that are viewed through an ECG. Depending on which group of leads are affected with ST elevation, we can figure out what artery is at risk and whereabouts on the heart tissue is dying. My apologies in advance if I've lost you with this one, because it seems like I've lost myself. But I will attempt to make a supported video podcast over on YouTube, but my editing is it's not great. So no promises at all. So let's go back to the treatment of heart attacks. The best way to treat it is to go to the cath lab. This is where they stent open your artery to bring back blood supply to the affected area. Another thing we do in ED is give GTN, triglycerol trinitrate, a vasodilator to open up blood vessels and supply blood to the heart. By increasing perfusion, pain should decrease. We also give therapeutic blood thinners to prevent clotting and further obstruction. Thinning allows for the blood to get through the partial occlusion as well. So you'll find that we'll often give aspirin, which is an antiplatelet, to help prevent any further clots. And then once we confirm that you're having a STEMI or an NSTEMI, we may start you on a heparin drip, or maybe even give you some therapeutic Clexane, depending on what the doctors want to do. So, in essence, STEMIs and NSTEMIs may seem a bit, what do we do? But they're easy enough to spot and treat. You just got to be fast about it. I almost forgot to mention the blood test that we do for cardiac muscle death in the event of tissue death is an enzyme called a troponin. This is released and helps us signify when there has been a cardiac event. In both STEMIs and NSTEMIs, we should see a rise in troponin as well as a continual rise until treatment begins, and then it peaks and then it will start to decrease. For obvious reasons, in STEMIs, the trops tend to be higher than NSTEMIs, but in NSTEMIs, because we can't see any ECG changes, the trop really is the defining diagnostic, as well as clinical symptoms like chest pain. Another condition that can cause ST elevation and a trop rise that isn't a STEMI is pericarditis, but we can go through that another day. So I spoke about the circuit and how intervals are important on the ECG. So let's discuss why. Although to understand why, we need to look at the electrical landmarks within the heart circuit. The pacemaker of the heart is called the sinoatrial node, or SA node. This is where we get sinus rhythm from. This node is located within the right atrium, and this is where impulses originate and start the cycle. From the SA node, it moves to the atrioventricular node, or AV node, which sits at the bottom of the atrium. The time it takes to get from the SA to the AV node is depicted very accurately, because it's in 0.2 of a second, by the PR interval that I mentioned before. And soon I'll discuss conditions that alter PR interval and what that means. From the AV node, impulses move towards the ventricles through what's called the bundle of His, which sits sort of on top of the ventricles. From the bundle of His, the pathway splits in two, which are called the bundle branches, because the bundle of His branches off. I don't know whether that was a good joke or not, to be honest. There's the right bundle branch and the left bundle branch. And these flow through the ventricles, and at the bottom of the ventricles we'll find the Purkinje fibers, which are ventricular pacemakers. Now, don't get me wrong, for an average Joe like you and me, unless you have a heart condition, the electrical pathway works just like that. An impulse generates at the SA node, moves to the AV, bundle of His, bundle branches, Purkinje fibers, and Bob's your uncle. But when I say ventricular pacemaker, I mean the last of last resorts for the heart to conduct electricity if all other sites are failing. So this being said, intrinsic pacemaker rates are as follows, and only come into effect if the previous one fails. So your SA node has an intrinsic rate of 60 to 100 at rest, which is obviously our normal heart rate. AV node has an intrinsic rate of 40 to 60 beats per minute. And the ventricles, the bundle of His and the Purkinje fibers, have an intrinsic rate of 20 to 40 beats per minute. Yeah, that's right, 20 to 40. It's quite slow. So we'll discuss the implications of this soon when I talk about blocks. which is coming very, very soon. Now, I haven't yet mentioned the QT interval again, and the reason for that is that it doesn't really have anything to do with pacemakers. The significance of the QT interval is for repolarization. If we think about the Q wave, it marks the start of ventricular depolarization, and the T wave is for repolarization. If the QT interval is prolonged and there's too much time between de and repolarization, not leaving enough time before the next heartbeat commences, if this is left unchecked, it can cause the heart to flick into a rhythm we may or may not have heard before on this podcast. Does VF sound familiar? Ventricular fibrillation, where there's pretty much no proper electrical conductivity happening. But, before this turns into a rhythm, Before this, it turns into a rhythm called torsades de pointes, or polymorphic VT. This is all going to be explained in detail on my mini episode on arrhythmias next, but today let's talk about heart block. Heart blocks are usually located at the AV node and the bundle branches, as we'll discuss now. There's an order to AV blocks, an order of severity. First is first degree AV block, or we like to call it first degree heart block. On the ECG, we'll see that the distance between the P and the R waves is greater than 0.2 seconds consistently. But there is no change to heart rate, and most people with first degree heart block usually are asymptomatic and don't even know they have it. Moving on the severity scale, we'll come to second degree AV block. Lucky for us, there's two types, aptly called Mobitz type 1 and type 2. You may also hear the word Wenkebach. That is in reference to type 1. So in essence, they both feature prolonged PR intervals and both lead to, in quotes, a dropped beat, meaning the P wave leads to no QRS and therefore skipped heartbeat. Depending on how often these dropped beats are happening, as they usually are regular dropped beats, this will determine what the patient experiences. So Mobitz type 1, or Wenkebach, whatever you want to call it, is when the PR interval progressively lengthens each beat before dropping QRS. So it'll be normal, then it'll be a little bit, and then a little bit more, and then significantly prolonged, and then no QRS, and then it starts from the start. And a Mobitz type 2 has the same prolonged PR interval until the drop beat. So it'll be prolonged, but it will not change between beats until it is dropped. As it is type 2, it obviously is more severe than first degree or second degree type 1, given its higher risk of progressing to third degree heart block, or what we call complete heart block. On the ECG, we now see absolutely no correlation between P waves and QRSs. They are working independently of each other. This means that a palpable heart rate will be the ventricular rate we discussed earlier, as the ventricles are not listening to the atria. On the ECG, this will also lead to a widened QRS complex, as an impulse originating from the ventricles will take much longer to get through, thus widening the QRS. Patients with complete heart block usually are symptomatic because their heart rate is sitting between 20 to 40. It's usually sitting in the 30s. And this is not nearly enough to adequately perfuse the body. If we think about our trusty cardiac output equation, stroke volume times heart rate. So, if our heart rate is now 30, and say our stroke volume is normal, if someone's in complete heart block, it usually isn't, but let's just say for today it is 60 mils. Cardiac output is 1.8 litres, as opposed to you or me with a heart rate of 80 and a stroke volume of 60 mils. That'll give us a cardiac output of 4.8 litres. It's a whole 3 litres difference in a minute. It's a significant difference. This is when patients become symptomatic, pale, lightheaded, dizzy, and drop their BP. So to combat first degree heart block, we don't because it's harmless. To combat second degree heart block, we usually don't unless they are symptomatic, because then we may give or stop medications that may be contributing. And to combat complete heart block, we'll need to insert a permanent pacemaker pretty much ASAP. And until then, there are options. You can chemically increase the pace through medications like isoprenaline, which works solely on beta-1 adrenergic receptors to act as an inotrope and a chronotrope, which increase rate as well as contractility. We can give atropine, which is an anticholinergic that reduces the parasympathetic nervous system and therefore increases heart rate. But it is unlikely to work in complete heart block and is more likely to work in sinus brady due to the atropine working on the SA node. But if that signal is not getting through to the ventricles and we give atropine, we'll see an increase in P waves because the SA node is, yep, we gotta pick up the pace, guys. But the ventricles, the connection's cut. So your ventricles, which are actually perfusing the body, will not change in rate. So usually atropine doesn't really work in complete heart block. If isoprenaline does not work, we can do what's called transcutaneous pacing. This is where we attach our defib pads and set it to pace. We then slowly increase the amperage until it starts to physically affect the heart. We can see that through what's called electrical and mechanical capture. Electrical capture will be evident by pacing spikes followed by a QRS at the rate we have set on the machine. And it's very obvious because it'll be pew, pew, pew at the rate you set. Mechanical capture is evident through sort of minuscule twitches that you'll see every time the patient is jolted. You'll see tiny little twitches. It can take a bit of fiddling to get it to the right setting, and yes, we usually sedate or at least provide pain relief before continuously shocking someone. One last block before we move on to the last topic of the day. Bundle branch blocks. Whether someone has a left bundle branch block or a right bundle branch block, it just means that either ventricle that is blocked, the electricity must take an alternate longer pathway. This will usually be noticeable through assessing the QRS complex of V1 and V6. In a left bundle branch block, you'll see sort of a William pattern, which means you'll see a W in V1 and an M in V6. And if it is a right bundle branch block, you'll see a Marrow pattern, an M in V1 and a W in V6. They're usually of little consequence unless it is a new bundle branch block. Then we must be suspicious if the patient is having an MI. Alright, thanks guys for hanging on. I'm just going to do a quick prelude into arrhythmias so I don't have to start from scratch next week. There are a whole host of arrhythmias we will discuss. Ventricular escape rhythm, where the ventricular pacemakers are outperforming the SA node, and the different types. So we've got accelerated idioventricular rhythms, ventricular escape rhythm, and then when this qualifies as VT, junctional rhythms, where the impulse sort of originates from near the AV node, not the SA node. So the P wave looks a little funky. And atrial fibrillation, one I've mentioned many a time, where the impulses are firing at all random times from all over the atria and not the SA node. This leads to no P wave, just sort of a little fluttery sort of baseline and an irregular rhythm. Atrial flutter, so two different AFs. How these AFs are different? When one particular pacemaker in the atria is firing, and it's firing on a fast loop, but then one in every 2, 3, 4 beats gets through, but the impulse circles back to the same pacemaker cell and it just keeps going and going. You'll see that they have a bit of a sawtooth pattern, and that the heart rate, even though it's an AF, a type of AF, it is regular. Next one, we've got AVNRT, or better known as SVT. And actually, another rhythm I may or may not have just mentioned also classifies as AV-NRT. This is when pacemakers after the SA node are stuck in an extremely fast firing loop and every beat makes it through. So you've got a heart rate in like the 200s. We'll talk about our Taki and Brady arrhythmia algorithms. All of the above arrhythmias are listed on these algorithms along with what to do. Then we'll talk about ventricular fibrillation, life-threatening arrhythmia like AF but in the ventricles, leading to zilch cardiac output, and ventricular tachycardia, the final fastest result of ventricular escape rhythms. And then finally, we've got polymorphic ventricular tachycardia, or as I like to call it, actually many people like to call it, Torsades de points. I'm probably not saying that right, but it's a type of VT that if not treated will turn into VF and an arrest. Anyway, thanks for listening to me ramble every week. I feel like my little lectures just get longer and longer. Today wasn't really about a specific person as much as a culmination of learnings I've picked up on, especially after finishing uni and starting an ED. There have been times where I've picked up on things that doctors have missed, especially pertinent things. And there have been plenty of times that when looking at an ECG critically, it has helped me adjust my care and provide for efficient escalation of care if I can see deterioration. So if anyone tells you that it's not a nurse's job to read an ECG and to just leave it to the doctors, respectfully tell them to shove. So this wraps up this episode of my show, Chronicles of a Learner RN. I certainly have learnt a lot today, and I hope you have too. I have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.